You heard a lot about pain and pain treatment already. Some introduction, but I will talk about, mostly I will focus on a different kind of drug class, opioid drugs. You already heard a lot about about the acute pain and the importance of treating sufficient treatment of acute pain, because this helps not only to reduce the pain, but also to improve the patient to maintain the function. But the important aspect of treating acute pain is also to prevent acute pain from progressing to the chronic pain. And pharmacological interventions with analgesics are usually the first-line treatment. WHO proposed, actually in clinical practice, a kind of a three-step progressive ladder is used, usually with the mild pain treated with anti-inflammatory drugs, and then moderate to severe moderate pain with weak opioids, and then severe pain, moderate to severe pain with stronger opioids. And it is very important that the treatment of the pain is sufficient, because the persistence of, as you have heard in the morning, the persistence of acute pain leads to the development of structural and changes in the central nervous system, and these structural changes are then much more difficult to treat. And the best way to prevent the development of chronic pain is early and effective treatment of acute pain. Opioids are commonly used in the treatment of moderate to severe pain, particularly, for example, in post-operative patient care or in cancer patients. And their analgesic activity is mediated by their binding to opioid receptors. However, their use has been kind of not perhaps sufficient due to or is medical doctors may be reluctant to use opioids because they may fear the side effects, which may range from milder, like constipation, nausea, vomiting, dry mouth, but also like more severe side effects, like respiratory depression, that may also be fatal, and the fear of addiction. So codeine, oxycodone, and tramadol are preferable options to morphine. They provide slightly lower or similar level of analgesia, but they have lower risk of side effects and opioid dependence. The problem of these drugs is that they are prodrugs, and they need to be metabolically activated in the liver to their active metabolites that are then able to bind to opioid receptor. And not all the patients, some patients may experience insufficient pain relief or higher risk for adverse drug effects when using standard therapeutic doses.
I'm really sorry, but we're not sharing right on Zoom, and someone just pointed it out, so we'll just...
Okay, so we're back. Oxycodone is the most potent analgesics between the three drugs and provides similar level of analgesia as morphine, but has lower frequency of side effects, particularly delirium. However, both oxycodone and its active metabolite are liable to abuse and can lead to opioid dependence. Codeine has better analgesic effect than tramadol, but several reports have been, several life-threatening or lethal respiratory depressions have been reported. So tramadol, despite its lesser analgesic efficacy, is compared to morphine, is considered to be relatively safe. It does not cause respiratory depression at therapeutic doses. It is less likely to cause addiction than other opioids, and it is widely used for the treatment of moderate to severe acute and chronic pain. So, which factors may contribute to these inter-individual differences in treatment response, both to tramadol and other opioids? So, of course, the first factor is the drug, the dose of the drug, and the compliance of the patient. Then it's biological factors like age, gender, constitution, physiological factors, concomitant diseases. Very important to be considered are drug-drug interaction, drug-nutrient, drug-smoking interactions, and other lifestyle factors. However, genetic factors may also play a role. And pharmacogenetics investigates how genetic variability in drug metabolizing enzymes, drug transporters, and drug targets influences treatment outcomes, both treatment efficacy and the risk of side effects. So, tramadol, for example, all tramadol, oxycodone, and codeine are extensively metabolized in liver. Here, for example, you can see how tramadol is metabolized in the liver. It is extensively metabolized by oxidation, demethylation, and conjugation. Cytochromes P450 are the first-line metabolizing enzymes, in particular, among them, CYP2D6 is particularly important because it activates the prodrug tramadol to active metabolite, O-desmethyltramadol, which is much more potent than the prodrug itself. Other cytochromes P450, like CYP3A4, CYP2B6, also CYP2D6, metabolize tramadol into less potent or inactive metabolites, and the glucuronidation actually it completely inactivates the metabolic products of glucuronidations are inactive, and they are then excreted via bile or urine, which are transported. So the products of tramadol metabolism are exported from the cell either via active transporters, especially ABCB1 and ABCC2, and organic cation transporter 1, which is also the transporter which enables this active metabolite to the transport of this active metabolite across the blood-brain barrier. So CYP2D6 plays a major role, the most important role in tramadol in the activation of the prodrug into active metabolite. However, individuals differ in their capacity for metabolism of CYP2D6 substrates due to genetic variability. And individuals who have two inactive alleles of this gene, they are poor metabolizers, carriers of one less active and one inactive copy of the gene are intermediate metabolizers. Then we have normal metabolizers. However, there are individuals who carry gene duplications and they express more enzyme and they are ultra rapid metabolizers. So the metabolic, the differences between in metabolic ratio due to this genetic variability may vary between individuals from 10 to 200-fold. And CYP2D6 is also the major culprit or the major factor which was shown then to contribute to little side effects of, for example, codeine treatment. There were several reports of neonatal deaths in codeine-prescribed mothers which were breastfeeding. There were also reports of severe toxicity and respiratory depression in pediatric patients treated with codeine after tonsillectomy and adenoidectomy, and there is a black box warning, and these drugs are not should not be used in children below the age of 12 years. So the active metabolite of tramadol, O-desmethyl tramadol, has 200 to 300-fold greater affinity for opioid mu receptor than tramadol. And tramadol and its metabolite also bind, actually also bind to serotonin uptake transporter and inhibit serotonin reuptake, and they also inhibit, in lesser extent, they also inhibit noradrenaline reuptake. So tramadol has multiple modes of action. We have performed a retrospective genetic association study in breast cancer patients who were treated with tramadol after breast cancer surgery with axillary lymphodectomy. These patients were randomized. This was a double-blinded randomized clinical trial at the Institute of Oncology, and these patients were randomized into higher dose or lower dose treatment with tramadol and paracetamol, which they were receiving for 4 weeks after surgery. We performed DNA isolation from blood samples and used PCR genotyping methods for tramadol metabolizing enzymes, opioid receptor MU1 polymorphisms, polymorphisms in microRNA genes that modulate the expression of opioid receptor, polymorphisms in serotonin pathway, and work on inflammatory pathway is in progress. And we looked for genetic association of between genetic variability in these genes and severity of acute pain, assessed with visual analog scale, and also association of these genetic factors with adverse events, chronic and neuropathic pain after 1 year of treatment. So these were the patients' characteristics. We included 113 patients. However, 14 discontinued tramadol treatment due to severe adverse events before the end of 4 weeks. And the majority of the patients who discontinued the treatment were in the high-dose group. However, we received information about which was the dosing group of the patients 1 year and a half after the follow-up was finished and after all the genetic analyses were completed. There was a difference in the analgesic effect. The pain perceptance was higher in the group with weaker postoperative analgesia. However, the patients could top up with other, let's say, with anti-inflammatory drugs. So adverse events were evaluated in 99 patients. And we looked for the association between tramadol metabolizing and, enzymes and transporters, and UGT2B7 polymorphisms and OCT1 polymorphisms were associated with discontinuation of tramadol treatment due to adverse drug reactions. And these associations remained significant after adjustment for tramadol dose. With CYP2D6, poor metabolizers experienced less constipation, and also similar results were observed in patients that received a lower dose of tramadol. With regards to outcomes, at 1 month after surgery, opioid receptor polymorphism was associated with constipation anytime during these 4 weeks of treatment. However, the polymorphisms in microRNAs that regulate the expression of opioid receptor were associated with nausea at 21st day of treatment, so after 3 weeks and after 4 weeks of treatment. 1 year after surgery, around 20% of patients experienced chronic pain, and nearly 25% of patients experienced neuropathic pain. And there was a trend for a lower neuropathic pain after stronger analgesia in comparison to weaker analgesia. There was no statistical difference between the two groups with regards to chronic pain. So the opioid receptor polymorphisms and 1 microRNA polymorphisms were associated with the increased risk for neuropathic pain, and 1 microRNA polymorphism was associated with the risk of chronic pain, but this polymorphism was very, very rare, and so the Fisher exact test was used for the analysis. So how do our data and our results compare to what is known about the genetic factors related to tramadol treatment? Pharmacogenomics knowledge base is the best database that curates the knowledge about the impact of genetic variation on drug response for clinicians and researchers. And if you should remember anything from my talk, it's that you can find this data in this database. So with regards, all the data from the literature is evaluated and assessed, and this knowledge is then integrated, and we can see that for tramadol, that genetic variability in tramadol metabolizing and transporter genes influences tramadol efficacy, toxicity, dosing, and pharmacokinetics, but not pharmacodynamics. And the major genes that influence tramadol, these phenotypes are CYP2D6. So the scale denotes the number of the studies that investigated these phenotypes with relation of genetic variability of these genes, and you can also see that other genes transporter and opioid receptor were also investigated, and catecholamine pathway. However, all these, despite the large number of this study, sufficient evidence of association or the impact of this genetic variability on the treatment, toxicity, efficacy, and pharmacokinetics exists only for CYP2D6. For other genes, the level of evidence is not sufficient. Either the studies were too small or they didn't give consistent results, so the level of evidence is low. For the genes or gene-drug pairs that reach such high level of evidence, the professional societies have prepared the evidence-based guidelines for the treatment. And for CYP2D6 and tramadol, both Clinical Pharmacogenomics Implementation Consortium and Dutch Pharmacogenomic Working Group have the guidelines with regards to how to adjust the treatment to different CYP2D6 phenotypes. As you can see, for opioid receptor, MU1 and COMT, there are no such recommendation because the level of evidence is too low. And what are the recommendations? The recommendations is that be alert to reduce efficacy of tramadol in CYP2D6 intermediate and poor metabolizers. And if tramadol is not effective, you should select another drug, alternative to tramadol, which is not codeine, for example. But for ultra-rapid metabolizer, alternative treatment should be used, which is also not codeine, because also codeine is activated by CYP2D6. Alternatively is to use this decreased, lower standard dose, lower only 40% of the standard dose, and to be alert of side effects. Also for codeine, there are also genotype-based guidelines for codeine treatment, which are similar in poor metabolizers. Tramadol and oxycodone should be avoided. There is, however, no recommendation for if codeine is used as cough medication, but for ultra-rapid metabolizers, also another drug different drug should be used, not tramadol or oxycodone or codeine. For oxycodone, there are not sufficient data. There are only a small number of patients were investigated, and there is insufficient data to allow any recommendations. So to conclude, evidence shows that pharmacogenetic variability influences outcomes of treatment with opioid analgesics, and genetic variability in tramadol pharmacokinetic pathways, so tramadol metabolizing genes may play a role in discontinuation of tramadol treatment due to adverse drug reactions and also risk of side effects. We showed this for constipation. Also not only tramadol metabolizing enzymes, but also the opioid receptor polymorphisms and opioid receptor regulating microRNAs may play a role in risk for side effects. They may also increase the risk for chronic pain and also for neuropathic pain. And so there are evidence-based pharmacogenetic guidelines that may support personalized and thus more effective and safer treatment with opioid drugs. So thank you for your attention, and I would like to acknowledge my lab, Jakob, and the master students, Jakob Jericha, who worked on tramadol pharmacogenetic genes, Zala Vidic on opioid receptor-related genes. Eva Kanalec is currently working, preparing the statistical analysis of polymorphism in serotonin pathway, and we are actually now trying to recruit a student who would work on inflammatory pathway. Savica and Tanya are the research who helped and supervised these students, and Katja Goriča performed all the statistical analysis. And I would like to acknowledge collaborators from the Institute of Oncology in Ljubljana who did the clinical trial. So thank you.
Any questions?